Good afternoon. So I'm going to go ahead and get started, even though there's only 9 of you, and I am recording this. Getting better about remembering, right? So wanted to go over the study guides and make sure that you guys had the answers to the study guides. And as far as your studies, so don't know how you want me to do this. If you want to just ask the numbers in the quiz that you want, or if you want me to start at, there's 3. So if you want me to start at 1 and go through all of them, anybody, any ideas? Nobody cares?
No, whatever you think works best.
Okay, then just let's start at study guide for 1. You guys still have that?
Yep.
I hope.
Yep.
Okay. Okay, so number 1 is what is standard precaution? It's the method of infection control in which all human blood and certain body fluids are treated as if they are known to be infectious. Did you guys have that?
Yes.
Okay.
Yep.
All right, and I'm not going to read the ones that are already written out. Then go down to number 4. It says know the categories of prevention. And if you have any questions about any of them along the way, even the ones where the answers are written for you, go ahead and interrupt me. Just stop me. So number 4 is know the categories of prevention. It's on page 8. You want to refer back. Excuse me. Swallowed down the wrong pipe. Primary prevention, those are what is carried out before the disease even occurs. It's to prevent disease or injury. So the primary prevention would be like sealants, oral health care instruction, fluoride in the community water, things like that would be carried out as preventive. Secondary prevention is, and so we deal with primary and secondary. We do not deal with tertiary, but it's primary, then secondary prevention. That's the treatment of early disease to prevent the further progression of it. So, so that it doesn't go into an irreversible condition like periodontitis. So that would include like removing calculus, biofilm, cleaning the teeth, scaling shallow pockets to prevent the fiber loss so it doesn't go on into perio issues. And so that's mainly where we go. And of course, we do primary prevention as well with oral home care instruction and sealants, etc. But tertiary prevention, that's the replacement of lost tissue. That's what a dentist does. He will replace the missing tooth. He will fill a decay, and that's lost enamel. So that's lost tissue, and try to get the oral cavity, try to make it better, as close to a normal healthy oral cavity as possible, but only after the secondary prevention has failed. So if we can't stop by oral instruction, home care instruction, and cleaning and scheduling them with the teeth, if they still are going to get cavities or perio issues, then that's where he would or she would step in and try to get it back to normal. Any questions about that?
Nope.
Okay, so then it says number 5 is state the technical name for herpes of the finger. I think you guys know that's herpetic whitlow. And for those who just joined, we're going through the study guides of the questions that you guys had to fill out. And we're starting with study guide 1. So then go down to 7. Says, know what makes a scientifically ideal mask and when a face mask should be changed. So what makes a ideal mask is that there's no contact with the clinician's nostrils or lips. And I find that to be a little difficult. I mean, it's fine. I don't know how you guys feel, but as soon as you start talking or breathing, it seems to me that there's contact. But anyway, ideal mask has a high bacterial filtration efficiency rate, that BFE filter. It fits snugly around the entire edges of the mask. There's no fogging of the eyewear. That's kind of a joke. It's convenient to put on and remove. It's made of material that doesn't irritate the skin or induce an allergic reaction. It doesn't collapse during wear or when wet. So those are what would make an ideal mask. And when the mask should be changed, you need to have a new mask for each patient. You need to change it every hour and when it's wet. And you need to keep it on after the procedure is finished because there's aerosols and all of that stuff in the air. So as soon as the patient walks out of your operatory, you don't just all of a sudden rip the mask off. Anybody need me to repeat anything?
Which study guide again? Sorry.
It's the study guide for quiz 1.
Okay, I got it.
Okay. Excuse me. Okay, number 9. State the principle of action for an autoclave sterilizer and which type of sterilizer takes the longest. You'll find this on page 104. It would be principle of action for an autoclave sterilizer would be sterilization by action of heat. It's pressure and heat. And Angelis, what we're doing is starting with study guide 1, study guide for quiz 1, and
Okay.
we're going through the answers of those that weren't asked before.
Okay.
Or weren't filled out. Okay, so the sterilization is because of the heat, and the pressure only serves to keep a high temperature. As the pressure builds, it makes the temperature go up, and then has to stay that the temperature has to be up, and the pressure, the pressure has to be so much, the steam for X amount of time before it's completely sterilized, which includes the cool down part of it as well. Sterilization depends on penetrating those packages and the ability of the steam to penetrate, which is why we don't stack our instruments up real high like they do in private practice a lot. I'll sometimes stack them up as high as I can. But if all that pressure can't get through that whole stack and only gets through partial places, then the whole thing is not really sterilized. It may even show that there's darkened on that tape. It may even go dark because of the heat, but it may not have been able to have been penetrated by the steam. Okay, so the sterilization depends on the penetrating ability of the steam. Air must be excluded out of the autoclave. There needs to be space between the objects. And the air discharge occurs in a downward direction. So it goes from the top to the bottom, and it's already has 3 stacks in it. So it needs to go to the be able to go from the top all the way to the bottom. And dry heat is always the longest. It takes 2 hours to sterilize. Ours takes 30 something minutes, which is kind of deceiving because it takes 30 something minutes to run its course with steam under pressure, but then it takes like another 20 or 25 minutes for it to begin to lose the steam and cool down. So you can count on about an hour. So number 10, know how hepatitis A and E and hand washing are related. Well, if you remember, hepatitis A and E are both from the fecal oral route of contamination, like food handlers, and through contaminated water. Also through contaminated ice is a really bad one when you get go through a fast food place or any restaurant and you get lots of ice, and you have to, really make sure, really trust, because there's no way to make sure, really trust the fact that clean hands are going in their ice and in the water to make the ice, because that's a key place to get transfer bacteria through the ice in our sodas. So how you eliminate that is that you're hoping that they wash their hands frequently, that they're frequently going in and using barriers and protection. Which hepatitis? Oh, that's already filled out. 12. Be able to state the length of time line should run at the beginning and end of each clinic day and between patients. I think you guys can answer this. 2 minutes at the beginning and end of each day and 30 seconds in between as far as your tests go. And I think you all know that we do this 30 seconds before and after. And I would just want to make a note here. I wish all of you were on here. So you'll probably hear this twice. Just really have to make sure that before you use your water at your operatory, that you run that for at least 30 seconds. And so you can turn your high vac on and just put that spout right over the high vac if you're not near a sink, and let that run for a good 30 seconds, because there's an awful lot that gets bacteria that gets up around the inside of those hoses. So you've got to make sure that you run it and kind of get that out, and especially overnight and over the weekends. Okay.
You said 2 minutes and 30 seconds?
Yeah.
Oh, okay.
2 minutes beginning and end, and 30 seconds in between patients.
Thank you.
So number 15 is know the 3 levels of disinfectants and a short description of their action. This is on page 106. So they're all divided into the 3 different levels due to their biocidal activity. And the cidal is the death. It's killing the microorganisms, the bacteria. So it's known by its ability to do that. So a high level inactivates all spores. It inactivates everything we need. It does spores, bacteria, fungi, viruses. It's a high-level disinfectant or a high-level sterilant is in that category. And hospital grades are usually in between intermediate and high levels of disinfectants, depending upon what their surface they're putting it on. So then you have an intermediate level. It inactivates all forms of microorganisms, but it does not destroy the spores. So just remember that the high level out of the three is the only one that destroys spores. Intermediate does a lot, but not the spores, and a low level disinfectant just inactivates vegetative bacteria, certain lipid type viruses, but doesn't destroy the spores, tubercle bacilli, which causes tuberculosis, or non-lipid viruses. So when we take soap and water and put it across our chairs and leave it and do that and then wipe it with something else, that's a low-level disinfectant. And that's why we do it, because that will destroy the lipid proteins. And then we'll go ahead and take an intermediate or high level, depending on if we use Cavicide. I'm not sure as if it's a high level or not, but I know Optums, I think they're intermediate. Any questions about that? Okay. 16. You'll find that on page 118 if you just want to look at the list instead. There's a lot to write out. It's give at least 6 descriptions of a neutrally seated clinician. So that would be a neutral seated position. Everything's perfect. Your back is aligned with your spine, natural curvature of your spine. Your head is right on top of your neutral spine with your neck flexing only 15 to 20 degrees or less. Your eyes are directed downwards so that you don't have to bend your neck. Your shoulders should be relaxed and parallel with your hips and the floor. Nothing is perpendicular. There's a question in here that talks about your shoulders should be perpendicular to the floor. So you'd have to be on your side to have that to be true. So nothing is that you want. Most every description is parallel or neutral, straight wrist, straight posture, straight with your feet flat on your floor, your wrist, your forearm and your wrist in a straight line. Your hips should be slightly higher than your knees. Your thighs you should have your full body weight on the chair, on the seat. There should be at least 3 inches between the edge of the chair at the back of your knee, and your knees should be slightly apart. And that's, of course, if you are working from if you're left-handed, a 4 or 5 o'clock position, and if you're right-handed, kind of a 7 or 8 position, because if you're anything other than that, you're going to be straddling the chair. And that's the only way that you can, if you straddle the chair and you have your knees parallel with your thighs parallel with the floor and your feet flat on the floor, then you should be okay, because you'll have an even distribution on the chair. Number 17, you'll find that on page 123. Know numerous strategies that help eliminate or reduce static loading. And static loading just is, once again, is meaning that it's the load that your body and spine and your everything takes all day while you're working in one position. Static means that there's no change. And we have a tendency sometimes to sit in the same position for hours. And so you do that for every patient, and 8 hours a day, X amount of days a week. The weeks roll into months and years, and after 10 years or so, you can be getting some neck issues, and sometimes it happens way before that, and sometimes we just tough it through until we need an operation, on our wrist or something. So what can you do? Physical fitness, make sure that you have your immunizations healthy diet, adequate sleep, patient positioning is correct, that you're using the correct instruments on the correct parts of the mouth. So then you won't be bending and kind of going upside down, trying to look. Exercise. You should be able to exercise throughout the day. Hopefully you're exercising, when you're not at school or at work. But if it's throughout the day, there's some hand exercises and neck exercises that you can even do a few here and there in between patients. So they're talking about also have a reasonable patient scheduling, which isn't always your choice. Sometimes they really pack those in there, and it doesn't seem very reasonable. So you're hurrying, which doesn't lead to being relaxed. Your body's not relaxed. And take adequate breaks, which is a very difficult thing to do as well in some offices. But that's what will help eliminate or at least reduce the static loading. So 18, know the importance of having your patient use a pre-procedural mouth rinse. We do that so that we can reduce oral bacteremia in the mouth and across the tongue. And of course, there's not even a controversy anymore. They've come out with evidence-based research saying that it isn't, that they're doing away with it. Really doesn't reduce that much. However, some of us just like to do that anyway, because we're kind of in their mouth the whole time they're there. If nothing else, it helps give it a better breath. Okay, describe the Trendelenburg position, number 19. Your head should be lower than your heart and feet. So state, wait a minute, no, 21. Page, you can find it on 120, I think 120, 1920 or 21. It says know the distance from the clinician's eyes to the patient's oral cavity in inches, be 15 to 22 inches. 22, describe the relationship between evidence-based dental hygiene and making a clinical decision. And the answer to that is that it is not enough to make a decision based on evidence alone. So you always have to, I know we've talked about that before, so I won't belabor it unless someone needs me to, but you need to use evidence-based information, but you have to consider the individual. It's not a cookie cutter. State another name for varicella zoster. Varicella is chickenpox. Zoster is shingles. 24, differentiate between an ultrasonic and an autoclave. Which one cleans and which sterilizes? So an ultrasonic, I think you guys know this too as well. Ultrasonic vibrates, uses sound waves through the water. It's a cleaning process. It cleans it, does not sterilize it. The autoclaves with steam under pressure will sterilize it. Number 25, you can see this on page, there's a box, I think, on page 17 or 107. And if you don't want to write everything down, it's if you're going to, your boss gives you the task of finding an ideal disinfectant. You want something that's broad spectrum, fast acting. You want it compatible with soaps and other chemicals that you may be using. You want it non-toxic. You want it to be okay on your the surfaces. There are some like Cavicide. Cavicide eventually will ruin leather chairs. And it takes a while. It could take a couple years, but then it will begin to dry it out and crack it. So you need something, which is one reason that we're another reason we're happy to use Optum. It doesn't do that. So surface compatibility, in other words, residual effect on the treated surfaces. It needs to leave some kind of a residue so it can dry off. It needs to be as odorless as you can get it. And of course, economical, not something that costs an arm and a leg. 26, describe Alfred C. Phones. He's the father and or founder of dental hygiene back in the early 1900s. 27, know if PubMed is an evidence-based search engine. Yes, it is. Wikipedia is not. Know the meaning of very solid summaries, and I have that on there twice. So that would be pretty much it to study guide for number 1. Do you want me to go ahead just so that you can hear it again? Do you want me to go over the questions that already have the answers written down? Or you want me to skip those? Anybody?
We can skip those. I feel like everybody knows those are correct.
Okay. All right, let's go to study guide for question 2. It's over chapter 10, 11, and 12. Okay, the first part, you've got to read through that. I know that there's some questions on your midterm that involves all of that information. So number 2 would be state how information collected at the appointment, permanent records, and legal evidence are all related. And they are all related because they're an official part of the patient permanent record. And they can all be brought up in a legal case, and they all belong to the patient, whether they've paid their bill or not. So number 3, know how patient records have been historically maintained. Historically, they were handwritten. They were paper, handwritten files. 4, state what HIPAA mainly protects, why it was created and what it stands for, and what year it was updated. It protects privacy, patient privacy. Why it was created, it was to protect patient records and other health-related information because of the ever-growing electronic information environment. And as people get more savvy to hacking in to things, it's going to be constantly emerging, constantly growing and changing and updating, etc. It stands for the Health Insurance Portability and Accountability Act of 1996, and it didn't go into law until April of 2003. And that's the year it was updated. All right, so let's go to number 7. Know which tooth numbering system was adopted by the American Dental Association, and that's universal. Number 9, you need to look at that chapter. They have on page 152 and 153. There are questions that were on your quizzes about the teeth and about taking teeth from one system to another. And so you would need to be able to go over that. There's probably 3 or 4 questions over that, the different systems. Number 5, know what color dental caries is charted on a manual chart. It's red. And in fact, it is charted that way in Dentrix as well. Some assistants who have used a Dentrix before, it will chart in black if there's decay, and we don't chart decay. What we'll do is chart that, like, let's say it's the occlusal of 19, the molar, and that is completely decayed. We don't chart it as black, we chart it as red so that it stands out to be treated. It is decay, but it needs to be treated. So it'll be red. Okay, 12, know which dental and dental hygiene procedures for which endocarditis prophylaxis is recommended. You look on, there's a box on page 179, and it's recommended for anyone who's going to manipulate, it's manipulation of the gingival tissue. Manipulation would be considered your probe and even your explorer. And of course, anything more than this, scalars, of course. But we don't even want to do a probe or explorer. Anything around the periapical region of the teeth. So if you were to put a probe or an explorer down the side of a tooth that was very close, you know, that had super deep pockets, or that had tons and tons of recession and it's just kind of being held there, we don't want to put anything down there around the periapical region of the teeth because it bleeds into, it's super easy to perforate, and then it's right there in your blood system. The other one is perforation of the oral mucosa. Any kind of, we don't want to cut it in any respect. Now it's going to be a little bit further down that we can, well, we'll just go there next. Number 15 is which procedures okay, wait a minute. Okay, so we don't have to, yeah, that's worded in kind of a strange way, but that's the way sometimes they word it. And what it means is we don't have to worry about endocarditis prophylaxis with a pre-medication. When you are doing just you can do a routine injection if and that's perforating the oral mucosa or the oral gingiva, but you can do it if it's through non-infected tissue. You can take radiographs. You can replace orthodontic appliances and brackets and place and remove prosthesis, you know, partials, dentures. They don't have to have a pre-med to do that. When they shed primary teeth, they don't have to have a pre-med to do that. And of course, you immediately think of children, but there are people, adults, who still have primary teeth, and they keep them like forever, but sometime once in a while they'll shed off, you know, and so they don't have to, even though it's going to produce blood, etc., they don't have to take a pre-med unless their doctor is recommending it. So bleeding from trauma to the lips or oral mucosa. So if you are cleaning their teeth and they have anything like that. Okay, 16. Does an antibiotic prophylaxis prevent a large or small number of cases of infective endocarditis? According to the American Heart Guidelines, it only prevents a small amount. That's why they cut back on doing it. So they used to think it caught a larger percentage of people, and through years and years of proven study, they finally said we've got 10 or 20 years worth of data here now, and how many people did it actually help. And they're like, it only prevented a very small number of cases. So what's the point? So anyway, number 17, explain about the maintenance to reduce the incidence of IE due to bacteremia. And maintenance would be, with bacteremia, would always be a pre-procedural rinse. 18, know the names of the highest and lowest blood pressure readings. Systolic, of course, is the highest. Diastolic is the lowest. Know the normal adult pulse rate and adult respiration rate range. So well-conditioned athletes, normal pulse rate would be between 40 and 60, while normal adults, 10 years older to adult, would be 60 to 100. I would know there's quite a few blood pressure questions, and where there'll be a blood pressure on the midterm, and it will ask whether it is hypotensive, like if it's too low, lower than normal, or if it's pre-hypertension, stage 1, stage 2, or normal. So I would know your respiration rates and pulse, go over those again, make sure that you know what the cutoffs are of the blood pressure. Okay, define pyrexia, and it means fever. 21, know what temperature is required for the following. In order to be considered hyperthermic, if you have hyperthermia, would be over 104. So that's when you're getting a fever. Hypothermia is under or less than 96 degrees Fahrenheit. You're considered to have a fever if you're over 99.5 Fahrenheit. It's not on there, but I thought I'd throw that in. 22, know the definition of blood pressure and a sphygmomanometer. And so the definition of blood pressure would be the force of the blood on the blood vessel walls. And so the systolic is going to be the force of the blood on the blood vessel walls during contraction of the heart, when it's just really spewing that blood out very fast and contracting. That's the systolic. And the force of the blood on the blood vessel wall while you're at rest is the diastolic. So basically it's the force of the heartbeat, is another way you could put that. So sphygmomanometer is the pressure measuring device. It's called a manometer, and an inflatable cuff to wrap around the arm, or sometimes even the leg. So it is the inflatable cuff. Name some factors that can increase blood pressure. Okay, exercise, eating, stimulants, emotional disturbances, if you're anxious or upset about something. And to decrease would be fasting, depressants, if you hold everything in a lot, and rest. Define cough sounds. Cough sounds are any sound you hear when you're taking the blood pressure. There'll be different kinds of, well, when you're taking your partner's blood pressure, it's how the strength of the sound, when you're first hearing it to where it just kind of gets weaker and weaker. Doesn't matter whether it's strong or weak, it's any sound during taking of the blood pressure. Know from which artery we take a pulse reading in the clinic. It's the radial. And the blood pressure stethoscope is put over the brachial. If you have some kind of an emergency and EMS comes, or one of your peers or family members just all of a sudden falls down and they're in some kind of medical distress, you try to take it at the carotid. And emergencies are always at the carotid. Know what the clinician should do when the patient's vital signs are not normal. So you are going to retake them and then refer to a MD if they are still abnormal. So sometimes it doesn't have to be an emergency. We've had it at the clinic to where someone's blood pressure is like 150 or maybe 162 over 105. Okay, so we suggested them very calmly that we will reappoint them and that they should probably go see their doctor. And so we don't give them a piece of paper with a referral of a name. The clinic can't do that, but we just tell them that they need to go. You know, it doesn't matter if it's Minute Clinic. They need to, who would probably, if they're that bad, refer them to a medical place because they're the only ones that have the equipment, the hospitals, to do scans, etc. Okay, define 27, tachycardia, bradycardia. Tachy is faster than normal heartbeat. Bradycardia, slower than normal heartbeat. Tachypnea, faster than normal respirations or breathing. Bradypnea, slower than normal breathing. So what is the normal blood pressure? Less than 120 over 80. Or any little number that may be. Any questions over any of that?
Nope.
Okay, I have something to say here. All right, they've changed this. On question 1, I just happened to, my eyes caught this. About 3 bullets from the bottom of the first question, it says, oh, I see what it, never mind. Ask if there is a need for pre-medication before manipulating the tissue in any way, including a probing or explore. Okay, I just read that wrong. So that is true. And you should ask. It used to just be given. I mean, nobody needed to ask because you just never did that. And now when they came out with the newer, like in 2017, around 2017 or 18, the American Heart Association changed some of that pre-medication things, and they lessened the restrictions for it. And so always be looking at those. If you ever want to find out what those are, you can always, if you Google and go into the American Heart Association, or you go into, I think, I was going to say periodontology, the Society for Periodontology. No, it's something else. The American Society of Anesthesiologists, ASA. It's what the ASA grades that we have for their health, ASA 1, ASA 2. So it's the American Society of Anesthesiologists. There, or the American Heart Association, they'll give you the latest list. So you should probably, when you're in private practice, kind of just keep current on that, and go into there once a year. When you graduate, you'll belong hopefully to your state's Dental Hygiene Association. And if you join that, I mean, they get together CEs and they let you know when all that stuff is happening. And they can also let you know when new things, are coming around. They may send you a little email that says an alert, look at your American Dental Hygiene Association for the new rulings on blah, blah, blah. But you can't just depend on that. You should probably once a year or so go in the American Heart Association or Society of Anesthesiologists, because they are going to have the latest. And that's what we go by. Okay, you ready for quiz 3? Our study guide? So on study guide for quiz 3, it would be number 3, attrition. And just remember that little hint that attrition you can remember from abrasion and abfraction, because attrition has 2 T's, and which means tooth to tooth. You can remember it that way, T to T. Tooth to tooth contact, and it's a wearing away. So abrasion is, bruxism is a type of abrasion. It's a grinding. And attrition is a tooth to tooth contact where the incisal edges can kind of split and crack a little bit, chip away. That's the one where the incisal edges of the central incisors can be all jaggedy from seamstresses, used to be hairstylists, I'm sure not anymore or for a long time, but carpenters, or if you have a habit of biting your cheeks, after decades of doing that, you'll start to notice little things on the edges of your teeth. Probably start to notice on x-rays a little bit of root resorption on there, or bone loss. A little bit of bone loss, not root resorption, a little bit of bone loss, because you're constantly putting pressure on the edges of your teeth, and they're not really meant to do that unless you're tearing food. So if you bite your nails in a certain fashion for years and years and years, then it won't have humongo effect, but you'll see these little differences, and that's what it's from. So attrition is a wearing away of the tooth, of the enamel from tooth to tooth contact. Bruxism, there's 2 types of grinding. There's a sleep grinding, and there's awake grinding. And they say grinding teeth in your sleep, of course, and they say you can also grind your teeth in the sleep from secondhand smoke. I don't know what that has to do with grinding your teeth, quite honestly, but the book says that. Awake, people can grind their teeth and without even realizing it due to stress. Certain foods, if they chew tobacco, any kind of little habits that they may have during the day, like you're biting your fingernails or whatever, and certain kinds of industrial dusts if you work around that. Abfraction, for some reason, I did not write down. I know what it is. I don't know if I can give you a technical. Anybody have that one?
For abfraction,
Yeah.
I have it is a V-shaped wedge with a hard, shiny surface.
That's excellent. A V-shaped wedge
with a hard, shiny surface.
Okay. and is most often caused by tooth to tooth, like pressure, tooth to tooth contact when your bite is not correct and your maxillary teeth are supposed to be slightly over your mandibular teeth, you know? And so if it's not, if you're kind of grind chew, if that makes sense, and you're kind of moving your arches kind of to the right and the left instead of kind of up and down more, you're putting pressure on teeth that weren't meant to have that much pressure on. It happens a lot of times. I mean, it can happen when you have all of your teeth, but it happens a lot in older people who are missing teeth. And so if they're missing a lot of teeth, then they only have a few uppers to maybe occlude with a few lowers that weren't to do a grinding or a biting and chewing. And so it's putting constant pressure on teeth that weren't supposed to have that much pressure. And it starts breaking off the enamel rods and down in underneath the tooth. And when it breaks those rods off, that's what makes that wedge. And it's kind of a slow process. Another reason a person can have that is if they, because usually with abfraction, you're going to have, not always, but most of the time, you're going to have recession. And so that's from them. It can be from really rigorous, wrong toothbrushing with a really hard toothbrush. So, okay, describe mesial occlusion class 3. It's on page 269. I'm going to let you guys write that down. It's a lot from, I mean, you're not going to write it down from what I say, but right under class 3, there's those pictures on page 269. It'll say class 3 mesial occlusion. And by the way, that profile would be prognathic. Remember, because we're looking at the placement of the mandible. So in this particular case, the mandible is pushed forward like pro, and their profile would be like a bulldog. But it's considered mesial occlusion because of the first molars relationship. That lower molar is way mesial to the maxillary mesial buccal cusp of the first molar. Distal occlusion, class 2, and that would be either division 1 or division 2. The difference, remember, is with the anteriors, whether those anterior teeth are kind of buck teeth or whether they're retruded kind of back in the mouth, and there's a lot of crowding. But in both of those pictures, you can see the molar relationship is exactly the same. It's distal occlusion because that lower molar is distal to where it's supposed to be. That mesial buccal cusp should be occluding with that buccal groove of that first molar, and the whole molar is distal. So this would be the profile of this person would be retro because the lower jaw is retro, it's pulling back. And then you have normal occlusion, where the mesial buccal cusp of the maxillary first molar occludes with the buccal groove of the lower first molar. And of course, the canine relationship is there. And just a malocclusion, which would be neutral, is when it's the same as the normal, but you have crowding and malpositioning of just individual teeth, a tooth here or there, or a group of teeth, which are usually anterior. So you can go back and kind of look at that again and fill that out. Okay, and number 4, the founder of the classification of occlusal would be Edward Engel. That's why we call it Engel class 1, 2, or 3. Number 5, overbite. You need to know the 3 classes of overbite. So you have a slight, I think it's on the next page, 272. So normal overbite is when the incisal edges of the maxillary teeth are within the incisal third of the facial of the mandibular. B is a moderate. That's the incisal edges of the maxillary teeth are within the middle third of the facial surfaces of the mandibular teeth. And C, of course, severe is where the incisal edges of the maxillary teeth are within the cervical third of the facial, or gingival third, you could say the same thing, of the mandibular teeth. Overjet. Overjet is the horizontal distance between the incisal surfaces of the mandibular, it would be the facial or labial incisal surfaces of the mandibular incisors, and the lingual incisal surfaces of the maxillary. And when it goes way over that or flares out, there's a distance between the maxillary and mandibular, or it flares way out, then you would measure that with the probe. 3 millimeters or less are normal. So you just say within normal limits. You would only really note something. You're only supposed to really note things that are anomalies or a little even slightly deviated from normal. So the next page, crossbite. It's on the posterior teeth, the maxillary or mandibular posterior teeth are either facial or lingual to a normal position. And the anteriors, the maxillary incisors are lingual to the mandibular incisors. Number 6, edge to edge. That's when the incisor surfaces of the maxillary teeth occlude with the incisor surfaces of the mandibular teeth, edge to edge. And I have cusp to cusp and end to end. Cusp to cusp is end to end. It's one and the same thing. You could say end to end bite is when you have cusp to cusp. It's like one molar directly on top of another. It doesn't fit into any groove. It looks like 2 bricks, one directly on top of another. Okay, so normal, moderate, and deep overbite. We've already gone through that. Oh, I didn't do open bite. Oh, yes, I did. Open bite is lack of occlusal or incisal contact between certain maxillary and mandibular teeth. When you bite down on your back teeth, all of your teeth should have an opposing tooth contact. And so if you look and you see that 1 or 2 that they're not contacting in any way, meaning that your maxillary teeth should be slightly over by, a third, the top third, incisal third of the teeth on a normal bite. And if all of the teeth are doing that, but you take your mirror and sit at a 12 o'clock position, and you can kind of take your mirror against the back side of the mirror against the lower lip and point it toward so that you can see whether those anteriors are slightly touching or not, and you can see where there's an open bite. You can also do the same thing in the posteriors, and you can have an open bite in the anterior and an open bite in the posterior, and maybe the teeth are just contacting around the canines and the premolars. And then you'd need to note that. Okay, so I think I've kind of gone through retrognathic and prognathic and mesognathic or mesognathic. The first molars are in a normal occlusion, but one or more may be lingual or buccal. So a mesognathic profile is just a straight profile. It's a normal straight profile. You might have one or two teeth that are kind of out, but not the whole thing or multiple. 8, contrast how the perioprobe readings are taken in millimeters for overjet. Overjet, they would be taken horizontally. Overbite, they're taken vertically, even though we never measure really over with a probe overbite. We just say whether it is mild, moderate, or severe. But if they ask that, it would need to be measured vertically. Number 10, state what proximal contacts are and what functions they perform. Proximal contacts, number 1, prevent food impaction because they're contacting. 2, they stabilize the position of the teeth so they don't drift around. And 3, there it goes, they prevent drifting. But they stabilize the position of the teeth as well so that not only drifting, but they can grow longer or they can start to rotate, all sorts of things if they're not contacting on their proximal, like in one arch, like your mesials and distals of all your teeth need to contact with the tooth next to it. And the maxillary and mandibular teeth need to contact. 11, state the use of the shepherd's hook explorer. So the shepherd's hook explorer is for smooth surfaces like the buccal and the lingual sides of teeth, or the facial and the lingual if they're anteriors. And then the other one is pit and fissures, which they include as one thing, pit and fissures, not two things. 12, describe the design, uses, and parts of a probe. A probe is slender. It's round. It has a blunted tip, and it's for examination of a sulcus or a pocket. The probe parts are, of course, a handle, an angled shank, and a working end. So number 3, list and describe the 4 types of manual palpation. You have digital, which is finger and thumb of your same hand. Hold on a minute. Then you have bidigital. And for some reason, didn't write that down, 196. So bidigital is the use of a finger and thumb of the same hand. Bimanual is finger or fingers and thumb from each hand applied simultaneously in coordination. And bilateral, our 2 hands are used at the same time to examine corresponding structures on opposite sides of the body. So bilateral, never mind, I'm not going to say that. Yeah, and they have pictures. If you go to page 196 and 7, you will see that. 14, know the advantages of following a systematic routine order for examination. Number 1 is for efficiency and time. and it's so that you won't forget anything. So what they say is it minimizes the possibility of excluding anything or forgetting it and for overlooking any little detail. So it promotes professionalism and it inspires confidence in not only you, but you look confident when you're doing that in a systematic way instead of going, oh, I did, oops, I forgot that, oops, I forgot that. So your patient has a lot more confidence if you're just doing your thing. They don't know whether it's systematic or not. It just seems all very smooth and that you know what you're doing. Number 15, know the sizes of a tumor. So a tumor is 2 centimeters or greater in width, and it's solid. It's a solid mass of tissue. A nodule is less than a centimeter. It is solid tissue, but it's larger than like a, oh, what's like a freckle? Like it would sit higher than that, but what you need to know is a nodule, it's greater than 5 millimeters. So think of your probe and 5 millimeters. So it's greater in diameter than 5 millimeters, but it's less than 2 centimeters. I would know the tumor and nodule thing for a question on your midterm. A bulla is large. It's fluid filled. It's not solid like a tumor and a nodule. It's filled with, it's like fluids. It could be serum or blood, a little mixed with a little blood. It's larger than a centimeter. So 16 is describe the look of an ulcer. An ulcer is usually described as a depressed lesion, or crater-like lesion could be another descriptive word that I've seen used. Depressed or crater-like. Define erythema. It means red or reddish. Oh, you already had that. 18, know the main reason we conduct intra and extra oral examinations. The most important reason, the main reason we do that is to detect cancer on the outside or oral cancer on the inside of the mouth, oral cancer on the outside of the mouth, and different kinds of cancer around the head at an early stage. We'd like to catch it at an early stage. So 21, know when mixed dentition occurs. It will occur somewhere between 6 and 12 years old. Usually when they get their second molars, second permanent molars around 12 is when we move from taking 1 bite wing to 2 on each side to 2 bite wings. In most offices, they need to have their second molar in order for you to take 2 bite wings on each side. So that's usually going to be around 12, 11, 12, 13, depending on the kid. Okay, so 22, be able to distinguish between a simple compound and complex cavity or restoration. So a simple is 1 side, compound are 2 sides and they run together. Complex is 3 or more sides that all run together as in 1. Do I need to go over those with any more description on those? No? Okay. So 24, what are incipient caries? They're newly formed caries. They are demineralized areas. where the minerals are being leached out of the enamel. They can be whitish or kind of yellowish whitish with no breakthrough yet to the enamel surface. So the outside, if you put the side of your probe across that, it's not going to like cave in. It may still feel really hard like enamel. And we never use anything pointed on there. So these are sometimes visible that we can just see. And sometimes remember the pictures of when we did the mirror. And I know one of you hasn't done the mirror yet, but you will see this, where you use transillumination and you put that light through the middle of the lower mandibular teeth, and then it's an indirect look into your mirror and fix the light so it's shining that way, and you could possibly see some newly formed or incipient caries coming from the lingual side. That is a possibility. But one thing, and I didn't see it in here, and I hope we still have it to come in this new edition, might be in a future chapter, but I remember on seeing this in several boards review books, and it talks about being able to see incipient caries, but you cannot see when the tooth is being remineralized. That is not going to be on your midterm, but I hope that you can stick that in the back of your head. So let's say that you have an incipient caries and it's just newly formed, or maybe it's still at the demineralization stage, even if it slightly broke through the enamel, but it didn't go very deep. You can use Pro-Enamel. Sensodyne's Pro-Enamel has an ingredient in there that helps to remineralize it, and it does wonders actually on little tiny newly formed decay. But if you get any, even somewhat sizable decay, that's not going to build up that much. But if you get these little tiny specks, it will. Well, when it's remineralized, it's putting the minerals back in that little teeny piece that has been, the minerals have been leached out of. And it can become nice and strong again, but you cannot visibly see that happening. Where you can visibly see a lot of times incipient caries because you can see the demineralized areas. Okay, so 25, most common site of a neoplasm. I added these in there. I would know the most common site of a neoplasm. It's the lateral side of the tongue, the floor of the mouth, your lower lip, and your soft palate.
Can you repeat that?
The most common site of a neoplasm. Plasm is like a growth. Neo is new. So it's some type of new growth that's in the mouth. The most common places that we see that are the lateral sides of the tongue. It's kind of, and that's why we twist the tongue and look at the underside of that lateral side. And the floor of the mouth. Lower lip, especially for people who are out in the sun. Farmers get that a lot from being out in the sun their whole life. They'll get it around their lips, especially their lower. And soft palate.
Thank you.
Add this. Know where the preauricular lymph nodes are located. I don't think any of you will miss that. Right in front of the ear. I want you to know the requirements for the development of a carious lesion. And there's 3 requirements. In order to make decay, you have to have some type of microorganism. You have to have a fermentable carbohydrate. And you have to have a susceptible tooth surface. So a really susceptible tooth surface would be like that demineralized area. So it's already minerals are being leached out of it. So you get more microorganisms on there with fermentable carbohydrates. And in other words, they have a lot of that on their teeth that's not being taken off. And boom, it's going to leach out even more and make a cavity. What you don't have to have for a cavity to develop is biofilm. You don't have to have biofilm for a cavity to develop. And you don't have to have calculus for a cavity to develop. But you do have to have one of these 3 things. And next, I want you to remember that what makes an ASA like 3 or 2 according to diseases. So an ASA 1 would be normal healthy patient. Could walk up 2 flights of stairs without any shortness of breath. They're in great condition. An ASA 2, they could have a mild to moderate systemic disease. So something in their system like angina or controlled thyroid diseases, controlled heart failure, chronic bronchitis, controlled asthma. Okay, so these people can walk up 1 flight of stairs, but they may have shortness of breath when they're finished. Someone who has extreme dental fears and anxiety is automatically a 2. What makes a 3, and so you jump back and forth, could be because they have like type 2 diabetes would be an ASA 2. Type 3 diabetes is an ASA 3. But aside from unstable COPD, if they have a pacemaker, they're a 3. Diabetes type 1, they're a 3. Heart valve replacement, they're a 3. But let's say that if they have a combination of 3 or more diseases from just class 2. Let's say they're a class 2 and they have chronic bronchitis, they have controlled asthma, and they're a diabetic type 2, and it's controlled. Because they have a combination of 3 or more diseases from the section of 2, it'll make them a 3. That makes sense? And then a 4, of course, is incapacitating. The type ASA 3 person, it may limit, it's not incapacitating, but it could limit their activity. They're able to walk up a flight of steps, but may have to stop periodically due to shortness of breath or lack of exercise, like me. Okay, so I want you to be able to know that systemic disease that limits activity but it's not incapacitating would be an ASA 3. Hold on. Okay, so I want you to know that when you are doing a perio probing, we note the numbers, but something else that we note is the bleeding points. And we kind of haven't gotten to that with you guys, or some of the instructors may have already. But we always note the number on a perio chart, and then we put whether we had a little bit of a hairline bleed or not. So it's bleeding points are part of the probing chart. So when you're collecting personal dental health history information, etc., what you're doing is that is under the part of ADPIDE that it is under is the assessment. You're assessing. All the data is in the assessment part of ADPIDE. I would know each word that ADPIDE stands for. I would know how a probe is used, the technique. Do you slide it? Do you walk it? Do you poke it? I would know that in order for the security of patient health information, we need offices that use computer technology, or if the office manager is allowed to take the office information home or connect to the office from home, they need to have encryption technology for protection of the patient. So other things that may be noted in the periodontal chart or record might be missing teeth, bleeding points, probing depths, the location of bridges and pontics and implants. So we usually chart missing teeth and location of bridges and implants on the restoration chart, but then it will show up missing teeth. All of that will show up on the perio. On some software programs, it does not. The missing teeth will. But we would not have in the perio record anything about their tonsils or their tongue or anything about their extraoral exam. Okay, if in a soap note, you would note the bleeding. If you wrote that down in a soap note, whether it would be in the subjective part, the objective part, or the analysis or procedures or planning, it would always be in the analysis. You would be giving them a bleeding index percentage, and it would be in the analysis under the A part of SOAP. Remember that a health history needs to be updated at each and every appointment. Questionnaire and interview are the best ways to complete a patient history, health history. Um, the patient's health history is confidential. So they call two different things updating, which can be confusing. You need to update their health history at every single appointment. In other words, ask them if they're on new meds, or if they've, since 6 months ago when you were in, or 3 months ago since you were in, are you on any new medication? Did you get off any of this medication, etc. So that's considered updating it at every single appointment. But then there's an update that you do that way, and then there's an update that you do annually with a whole new sheet of paper, like you do for the updates during the year. You can just kind of go to your computer, or if it's paper, you go to that sheet and make sure that if any changes need to be made. But you don't have to do a whole brand new medical history sheet. But you do have to just update it and see what's going on. But once a year, you need to update with a whole new sheet. Now, as far as if they're going to have a lot of that on boards, because most people don't use sheets anymore, or at least they'll use a combination, like we do a first-time paper, scan it in there, and then anytime that you will do a new health history, we're just not doing them every single year, the sheets, to cut down on paper because of COVID. But forever, when it becomes their year, they fill out a brand new sheet, and then you scan that. And then the second, whenever else they come during the year, you just see if there's any changes, but that's also called updating. But none of it is written in pencil, and minors don't have to sign anything. If they are minors, it's the parent. Okay. So you already know that patients that are currently taking an antibiotic would require a different class of antibiotic if they needed an antibiotic prophylaxis, and that it needs to be taken before or after, but not before and after the dental appointment. What they're trying to prevent is the creation of bacteremia going throughout the blood. So this is already 5:30. Some of you may need to go, and I'm going to go ahead and be recording that. So if you do need to go, you can, but if you want to hang, I'll go over some more. You might need to know. So we had this on one of the quizzes. Which of the following is not an appointment procedure consideration for a cardiovascular patient? And it would be increased bleeding. We thought that that possibly could be one, but in fact it's not. So that would not be a consideration, bleeding, for cardiovascular. Okay. So fasting would not increase your blood pressure. In fact, we were, I think we just went over it in one of those study guides. It probably would decrease your blood pressure. Um, So if you have I think we had an example of this on one of your quizzes. Someone shows up at your office and they come in and with some unknown heart condition that they need a pre-med for, and they don't have one, and if your dentist doesn't have one, and now they have to reschedule or postpone the appointment and come back. And one thing that could have stopped that is if it's even a new patient, especially, is if the screening from whoever's making the appointment for that person, and to be just ask them real quick if they're in need of any pre-med, they should bring it or take it. Okay. Also, that if you call their doctor, they need to send a written statement back. If your doctor says, oh, they don't need a pre-med anymore, you can go ahead and finish treating the patient. But what needs to go in their documentation is they need to fax over or email over some kind of a written statement with the doctor's name on it stating that they don't need one, or they do still need one. We've had them do that. Maybe they still want someone to take it. So let me ask you guys, is a self-examination by the patient at home of if they look in the mirror for their oral tissues and they do a self-examination, is that sufficient to detect cancer?
No.
Right. Okay. No, it's good. It's a good thing that they do that, but they still need to come periodically to a professional dental personnel to be able to look at that better. Okay. Okay, we've kind of gone over. Let me look here real quick. Yeah, I'd brush up on the mesognathic and prognathic class of occlusions. We've kind of gone over. Anybody remember what parafunctional contacts are? These are contacts of the teeth. So if they're functional contacts, they're all fit. Your maxilla and your mandibular arches are all fitting kind of where they need to be, right where they inside the grooves and inside the teeth. But if they have a parafunctional contact, what does that mean? So parafunctional would be just outside of the normal range of function. Just something that's, you know, maybe you have a tooth or two that's going in a different direction, and maybe it makes crossbite because of one tooth being out, but it's also, you could also say that has parafunctional contact, but it's outside of the normal range of contacts. So if you get any questions on the midterm about when to flush your water to, you know, at the between patients or at the beginning and end of the day, go to what your boards would likely say, not what we do at our office or at our clinic. So anybody remember where calculus occurs most frequently on? What
Your
teeth?
lower anteriors.
The linguals of the lower anteriors. And where on the or buccal of the maxillary teeth. And one of the reasons they do on the lower anteriors is because you have that big Wharton's duct and caruncles down there, salivary glands that are constantly bathing those teeth. So you have another salivary gland in your mouth on both sides of your mouth. And they lay right up next to your parotid. Their parotid glands dump saliva through Stinson's duct, and it's just opposite of your like first and second molar, or second and third molar. And the one place that gets the worst are your facial or buccal molars, especially on the distals of those molars, of the first and second molar. It can be a lot more calculus there, where there won't be on the lingual side of the maxillary, but there will be on the where it's sitting up next to that salivary gland. So anybody remember what the function of cementum is? Cementum goes around the root of a tooth. So it's that thin layer that goes, encompasses the root, which is the dentin of the tooth, and it's just that little thin layer. And what that does, it's rough, and it provides attachment of all those fibers that will hold the tooth in the tooth socket. So it provides for fibers attachment. Okay. We already talked about PubMed being a good search engine. So your ultrasonic and your autoclave. Need to know which is we just went over this, the cleaning, which cleans and which sterilizes. You're going to name all your standard PPE barriers in order. And it doesn't include the shield or anything. And I don't know if they'll include the kind of PPEs that we need to use today on boards or not. They'd have to redo. I just don't know. So they don't have them in the books. We're just going to know it the way the book says it. I'm gone over those. I'd know when you need to use your utility or heavy duty gloves. So it should be cleanups and setup of your dental operatory and processing of any contaminated instruments. I'd know, and we talked about it, the method of sterilization that takes the longest. Do you guys remember what virus Epstein-Barr makes?
Mono.
Yeah. Mononucleosis. Okay. Okay. I think if you know all that, you'll do pretty well. You guys have any other questions? There's 100 points, 100 questions. They're worth a point apiece, and it's all multiple choice. Gosh, I didn't even think about that. I don't think there's a true and false in here. There may be one or two, but I honestly don't think there are. I think it's all multiple choice. So no matching or anything like that. Anybody else have any questions?
No, thank you for going over this with us. I really appreciate it.
You're welcome. You guys have a good evening.
You too.
Thank
you. Bye.